we're going to talk, well, Kathy and I are going to talk about some of the issues around transitions. We're going to talk about some of the issues that occur in teenagers and young adults with autism and autism spectrum disorders. And I'm going to start with obsessive compulsive disorder, which is the OCD in my title, for those of you who don't know. Obsessive compulsive disorder is an area of research that I've been involved in now for about 15 years. I run a clinic for young people, not with autism and autism spectrum disorders, but for young people with obsessive compulsive disorders. And obsessive compulsive disorders are those disorders, and I'll show you a definition in a minute, which are a disorder which is fairly constant through life. People who get OCD tend to continue to have OCD, and they have exacerbations when it gets worse, and then it also gets better. I'm briefly going to cover the definitions of autism and obsessive compulsive disorder. And I'm going to talk a bit about whether we can be sure that what we're seeing is obsessive compulsive disorder, because one of the things that people often talk about is they often talk about the obsessions of people with autism or autism spectrum disorders. And I don't actually think they're using that term in the technical sense that people in the health service would expect. And the reason that I think that's important is that I think you would do quite different things if you could understand the difference between stereotype behaviours or special interests and obsessions and compulsions. There are a number of disorders where repetitive behaviour is quite frequent or is part of the definition. One of them, for instance, is trichotillomania, which is people pulling their hair out. You may think that's a very odd thing to do, but again, it's one of the things that I see in clinical practice. I see people, young people come to me and they've got bald patches at the sides of their head, and it's usually in a very characteristic pattern. One young woman I worked with used to pull her eyelashes out. Some of you may well pluck your eyebrows, but would you actually take your eyebrows out completely? And I know Zandra Rhodes, who's a famous fashion designer, has removed all her eyebrows, but it's not normal to pluck your eyebrows to nothing. So that's a repetitive behaviour. There are repetitive behaviours too in a disorder called Gilles de la Tourette. And Gilles de la Tourette is most commonly thought of as being the disorder where people swear uncontrollably. But you can also have repetitive movements, and the repetitive movements can look very similar to those in autism spectrum disorders. And one of the young people I helped to look after with Gilles de la Tourette had a most wonderful Star Wars style movement, and he would get up in class and he would do this. Now, that's actually not great for class cohesion. It tends to distract other people. The teacher is usually quite put off as well. But as far as he was concerned, it was almost uncontrollable. And there's a big issue about how tic disorders like Gilles de la Tourette should be controlled. Now, as it happens, many young people get tic disorders. And tic disorders generally start before adolescence or just at the beginning of adolescence. OCD tends to start during adolescence, at least we think it does. I have some doubts about that, but we don't need to worry about that. But the other thing is, people have interests. You know, why? And I really don't understand, why do people run 100 metres? You know, what is the point of running something that only takes you 10 seconds to do? And they do it time after time. Some people run a mile, and they get paid lots of money for doing that. Well, actually, the people who run 100 metres get paid a lot of money for doing it, but only if you get very good. Is that a repetitive behaviour? Should that be a stereotype behaviour? I'm not going to give you an answer. I don't think there is a simple answer. But I want you to bear in mind that those of us who pursue a course of action, almost to the exclusion of other things, may be doing exactly the same thing as someone with an autism spectrum disorder. And the final part of my talk is going to be a bit about treatment of OCD. And I'm not going to give you an answer, because I think there isn't a clear answer around at the moment, and I'm not even sure that we are very clear about where we should be looking. Okay, the definition of autism, as you all remember, 3 characteristics. Gary Mezeboff and I were talking about this only yesterday. Curiously, in the diagnostic instruments, we concentrate on the first 2, not on the third. And you might sometimes argue we also ought to include some sort of sensory interests in there, or sensory abnormalities. It starts before the age of 3 years, usually, almost always. What about OCD? Well, this requires that you have both obsessions and compulsions, for most people anyway with OCD. And the obsessions are repetitive thoughts, images or urges, so that can be a feeling that you have to do something, which is extremely uncomfortable. There was one young woman I worked with whose repetitive image was of the school hall, and that was enough to send her into a paroxysm of repetitive behaviour. The repetitive behaviour is what we call a compulsion. More commonly, people worry about cleanliness, they worry about contamination. And it's a very odd form of contamination. It's not contamination that a health and safety expert would recognise, which leads them to put up notices in every hospital toilet saying, this is how you wash your hands. You have to do it palms first, then between the fingers, then round each finger in turn. Just think on for a moment, how long does it take you to wash your hands? Is it more than 10 seconds? 20 seconds? Have you ever had a nurse shine a blue light on your hands afterwards to see how many bugs were left on? I can tell you there'd be millions. Nobody washes their hands properly. And I saw some appalling statistic about the bugs that are found on mobile phones. We don't think people use mobile phones in toilets, but I may be wrong. Now, the repetitive behaviours are the compulsions, not the obsessions. The obsessions are the repetitive thoughts, and the thoughts are unpleasant. The behaviour, the repetitive behaviour, the compulsions are designed to remove the unpleasant feeling. And you and adults report that they don't like those things. Children, they're not so clear about those reports, but in general, people with OCD do not like having their repetitive behaviour. And it's very clear both from their demeanour and from what they say. But the children at this school and the adults who are now living in our adult living provision don't always talk. And certainly if they do talk, they don't always give me a straight answer. Or maybe I don't ask a straight question. So the point is that both disorders have problems with repetitive behaviour. And then the question becomes, are these different types of repetitive behaviour? Does the reason differ? Is it possible that someone with an autism spectrum disorder also has an obsessive compulsive disorder? Now, as it happens, we know from other studies of other types of mental health problems in childhood and in adulthood that it's quite rare to have one disorder without another. And then, even if they do have the same type of behaviour, does that mean they need the same type of treatment? It's quite clear that if you're teaching people with autism spectrum disorders, you don't teach them in the same way as you teach somebody with no communication difficulty. So why would you expect to have treatment that was the same? That doesn't mean we shouldn't try, but it does mean we need to be aware that there may be big differences. Now, this is some work that was done fairly recently in Australia. It's in a fairly small group of 12-year-olds, or about 12-year-olds, and it uses the first 3 sets of columns are scale scores from something called the Repetitive Behaviour Questionnaire, which was designed for people with autism spectrum disorders. And they're comparing people with autism spectrum disorders, which is a sort of greeny colour. Sorry, being a man, I don't actually know the difference between green and blue, as you'll probably appreciate. So I call this colour green, yes? Is that all right? Everybody can understand that? And this colour is blue. This one, at least, I think we can agree is red. Well, maybe not, actually. Perhaps some people would say it was orange. Anyway, from this angle, I'm going to call them green, blue, and orange. Orange are controlled children. They're children with no problems at all. Blue are children with obsessive-compulsive disorder, and green are the people with autism spectrum disorders. And in terms of behaviour, the people with autism spectrum disorders look very similar to the people with obsessive-compulsive disorder. And they look very different from the people with no problems at all. But in terms of something called the CY box score, which is a measure of the interference of the repetitive behaviour and the thoughts that go with it, the scores are very different. The people with autism spectrum disorders are almost halfway between the people with obsessive compulsive disorder and the normal people. That suggests we're not dealing with exactly the same type of thing. Although it looks as though, just watching them, as though it is the same sort of thing. So it's quite understandable why we would use the same language to describe them. So what about comparing it with hobbies? How many people secretly believe that train spotters have autism spectrum disorder? Rather a lot of you, I suspect. I'm not asking for a show of hands. Maybe I should, actually. I think I ought to confess. Actually, I'm not a train spotter. I just can't get you, I don't understand the point of the numbers. Anyway. But do you know where else there are numbers? Have you noticed there are numbers on motorway bridges? Have you noticed that there are numbers on lampposts? And of course there are numbers on buses. But if you're interested in the numbers on buses, is it a form of OCD or is it just an interest? If you see a bus with a new number on, why wouldn't you follow it to the end of its route? That's a perfectly reasonable thing to do. And similarly, if you're looking at lampposts and number 53 is missing in the sequence from 52 to 54, that's clearly a problem, isn't it? I bet you the Highways Authority would not be happy to find that we're missing 53. No, I don't think lampposts are cheap. Have you ever tried to buy one for the garden? Not that I'm that interested in lampposts, honestly. So that is maybe a hobby, but also those are the things that people that I have known with autism spectrum disorders have gone and collected. They've gone and collected the numbers of lampposts. They've gone and collected the numbers and the routes of the buses. They've gone and collected the numbers of the... Well, actually, they haven't. I've never yet met someone with an autism spectrum disorder who was interested in the numbers of trains. But if you stand at the end of Reading platform, Reading's a very good train station to go to, by the way, because there's lots of trains going lots of different places. There are little knots of people looking at the train numbers and taking photographs. Do they spend their time on their own? Not usually. Usually they actually talk to one another. Is it a hobby or is it a sign of an autism spectrum disorder? Okay, their fashion sense isn't up to much. But then my wife would say the same about me, so. Okay, so here are some types of behaviour in different groups. And first of all, we just try to find people with interesting hobbies. And I can tell you there's some very interesting hobbies out there. We did come across a man who was collecting Victorian ladies' underwear. We didn't interview him because the person who was working with me at the time was a young woman and she felt a bit uncomfortable going and asking a man about collecting Victorian ladies' underwear. Can't understand why. I'm sure it would have been safe. But she didn't. And you know, local museums are full of collections amassed by people who otherwise have been quite successful in life. They're not like people with autism spectrum disorders who often have difficulties fitting in. So what do people with hobbies do? Well, they do things like they collect things. That's the most common thing that we found. So there was one man we found who collected minis, old minis, not the new BMW-made minis, the old type of minis. And his garden, front, back and side, was full of bits of mini. There were even a few minis that drove places. And we asked him why he did it. It's great fun. You have no idea what it's like to collect minis. Did you know there are mini club meetings in pubs? That's what he did it for. He put together a mini, took it along to the pub, and they had a long, long discussion about how to keep the engine clean. I can't do it, any more than I can discuss motorway junction design with a young man with autism who used to live near me. Or how many weather forecasts there are on the television between 6 o'clock and 9 o'clock at night. And whether there's going to be a thunderstorm over Thatcham but not Newbury. Because that's where the cloud was. That's where the cloud with the lightning was. It was over Thatcham but not Newbury. Okay, so that's collecting is common. People get interested in birds, and the orange triangle you can see is quite a big, or the orange pie slice is quite a big pie slice here for the people who are typically developing, but it's also here in the people with autism. Similarly, interest in history. People spend a lot of time doing stuff like family history and local history. There are lots of thriving local history groups. And that doesn't come up so much, but then transport does in the people with autism. I try to keep the colours the same, but as you can see, I haven't quite managed it. But collecting doesn't seem to be so much of a feature of the people with autism spectrum disorders. But in terms of the motivation, I think there's something different. Now, is this OCD? No, it's not OCD. If you're interested in trains, you look for trains and it gives you pleasure. If you've got OCD, you look for germs and you're frightened of it. You're upset by it. You're disturbed by it. You're distressed. So you go and wash your hands. And you don't just go and wash your hands. You don't just go and wash your hands the way the hospital tells you. You may wash your hands and you may get actual marks of red all the way up your arms. Or you may be worried that you've got contamination somewhere else on your body. So there's one young man I knew who washed his chest with bleach. That's what happens when you have OCD. So those are the sorts of things that can happen in an obsessive compulsive disorder. So we decided we really ought to understand why people were doing these things. And we do this clinically anyway. But if you think about these questions, the sorts of questions we would ask in a clinic session to someone who can speak well, I mean, I don't know what Ros would think. If I asked her these questions, she'd probably stop answering me after a while. She'd say, why are you asking that? Or I don't know. And I'd have to infer, I'd have to try and work out what her feelings were like. Now, curiously, if you do this to people who pull their hair out, they say they don't really know why they're doing it, but what actually they're doing is that they feel uncomfortable. And quite often they have felt that one hair is different. How many people in the room worry about split ends? This used to be a great thing in my youth. The young girls were talking about split ends all the time. Sorry? Oh, conditioners are better now, are they? Oh, is that what the answer is? Right. Oh, I didn't know that. Right. Okay, well. Okay. So people used to worry about split ends. Some people worry about getting grey hair. Okay. But that's, well, that's normal, isn't it? That's not a stereotype behaviour. That's not an obsessive compulsive disorder. But people who pull their hair out feel an odd hair. They feel a hair is out of place, and they pull on it, and they pull it out. And it makes them feel better. They're escaping from a feeling of discomfort, and that's almost exactly what is described in obsessive compulsive disorder. And if you ask about the thoughts of people with ASD and OCD, what you find is that the types of thoughts that people are getting are different, or somewhat different. So people with OCD are much more likely to have aggressive thoughts, according to this guy, McDougall, in 1995. They get thoughts about contamination, sexual thoughts, religious thoughts, thoughts of blasphemy, that means really. And that's one of the earliest forms of OCD is actually described, is some lovely 17th century descriptions of what are called moral scruples, which are, we would now call religious doubts. They worry about symmetry. Oh, symmetry? I'm sure that's something to do with autism spectrum disorders as well. And they worry about their health. They worry about somatic things. They worry about things that are wrong with their bodies. People with autism spectrum disorders are more likely to worry about where things are, where they put things, which is what we call hoarding. Have they still got everything they used to have, their belongings? And they often do things repetitively about needing to know. That's not surprising. If you think about it from their point of view, it's actually very difficult to know what's going to happen next. And our study of hobbyists, what we found was that people with ASD described their thoughts as interfering with what they should be doing, like work, but they're not actually distressing. That's not the case in OCD, and in hobbyists, they don't really find that their thoughts about hobbies interfere with their work. I'm not sure if that's still the case with the availability of eBay and everybody working on the internet all the time, because I rather suspect these hobbyists are actually spending 50% of their working lives with an eBay screen open in the background. Sorry, this just says the same thing, that in OCD it is the thought that is distressing. That is not the case for ASD in general in our study, and it's not the case in general for people with hobbies. And if you're actually doing the thing that you do repetitively, what's it like? Well, if you stop someone with an ASD doing what they like, they don't really like it. They get upset about it. hobbyists do somehow seem to cope better with that. But in both cases, it's a generally positive experience. So all that repetitive behaviour does not look like obsessive compulsive disorder. It looks like something different. It looks like an interest. It looks like a hobby. And this was a lesson I learned many years ago in Borough Court Hospital when we worked with blind children who had amazing repetitive behaviour. They could do things like spin plates. Well, they could spin anything, actually. And we always wondered what it was that they liked. But I'm sure it was the sounds that the things make. If you spin a plate, particularly sort of like the plastic plates we had in hospital, they make a really wonderful noise just as they start to topple over. It's a sort of noise. And that's nice, if you haven't got much else to listen to, apart from all the noise from everybody telling you what to do. But there remains a concern that people with ASD have obsessive compulsive disorder. And a number of studies have been done on this. Quite an early one from Canada is the Sadmari et al. Study, where he reckoned that about 19% of the people with Asperger's syndrome had obsessive compulsive disorder as well. Don't worry about the study by Green, but the study by Ailsa Russell in 2000, which was published in 2005, compared directly young people with OCD with young people with ASD. And what she found was that those people with ASD who seemed to be distressed by their repetitive behaviour didn't have quite as many problems with their worries about their body or repeating or checking. But they were reporting significant interference and distress from their rituals, but still rather less than those people with OCD. So people with OCD looked more severe, but they were still being distressed. They were still upset. And this is a couple more studies, more recent studies. The adult study is done in America, the ASD adult one, and you can see there that they were reckoning that using a standardized clinical interview, about 37% of the population with autism spectrum disorders had obsessive compulsive disorder, that is compulsions that are distressing in some way. In the child population, working with Emily Simonoff in London in the SNAP study, it's about 8.2, whereas what you'd expect is about 1% or maybe 0.2% in normal children, which are the last two columns. The TD, sorry, it's using American terminology here, or I haven't put, is typically developing adult, typically developing child. And you look just at the yellow line, don't worry about the others. Well, you can see here, this is the adults with ASD. 37% may have obsessive compulsive disorder, or 8% of the children. And I think that probably does correspond to my own clinical experience. There really are a number of people with autism spectrum disorders who do look upset by their repetitive behaviour and for whom we do actually want some help. And the types of problems are very similar, with the exception of the somatic symptoms, the worries about the body. But in terms of the behaviour, there are certain significant differences. And I think it's quite surprising that there is less repeating in the autism spectrum population than there is in the OCD population. There's also less counting. Counting's quite an interesting one, but that's because in our world we have a lot of things like lucky numbers. How many of you think that 13 is unlucky? And if I was to go round the room and ask you what your lucky numbers were, I'd come up with all sorts of strange numbers. And it could be anything. 8 is lucky in the Chinese number system. Some of the children I've dealt with have said that 3 is unlucky because it's an odd number. Well, all odd numbers are unlucky, but a lot of people say that 7's a good number. How do you decide? What's the system? There isn't one, just in case you were wondering. Everybody has a different number to worry about, in my experience. So 6, of course, is quite often a bad number. Anybody know why 6 is a bad number? It's the number of the devil, someone said, I think that's right, because of 666, which is in the Bible. Although I'm told by my son, who's far better educated than I am, that that's a mistranslation in some way, but I can't remember now the details of that. You can have an argument with Jack next time. You know? Sorry, Father Oliver, who's one of the trustees here, knows my children. I don't think you educated them, though, in any way. Okay, now, I'm going to show you some behaviours, and I want you to think, Do these look like OCD or do they look like repetitive behaviours? No, hang on. That's what I have to do. Okay. This is somebody who's trying to, well, who is supposedly going through a door. Actually, these have got in the wrong order, I think. He's not making the noise, that's someone else. Why has he stopped like that? You know, why is he finding such difficulty going through the door? And actually, what you can't see is that some pressure is being put on him, but if someone is holding his back so that he has to move forwards. But if you try and do that with him, I can tell you you can't. You can't actually, you can literally physically force him to move forwards a step, but he won't move then any further. He will go back to where he was. This is just showing you how his feet remain absolutely stock still. Is that because he likes standing there, or is he distressed? Now, you can't tell because you can't see his face. And even if you could see his face because he's got an autism spectrum disorder, you still might not be able to tell. You have to know someone really quite well. But I would say he's not actually comfortable getting stuck like that. He really doesn't want me to push him through. It's not actually me standing there, I was filming. Now I've gone round the other side now, and this is about a minute later, I suppose. He's completely stuck. Now this behaviour I see also in typically developing adolescents with OCD. Not commonly, but often enough. So you'll get somebody who can't cross a line. And you may not have noticed, but there are lines in the floor. There's one here. And I might have difficulties getting over that line. And if you ask me why, and I don't have an ASD, I will say, I can't cross it unless I'm thinking the right thoughts. This is dangerous. Now, that doesn't make any sense, does it? It's not really dangerous. But we have a children's song, Don't Step on the Cracks. Now, is it the bogeyman, the bear? What gets you? Everybody has a different version. Perhaps this is the same thing. Oops. Now, I want to go back and show you. Well, I should have labelled these a bit better, shouldn't I? Right. Okay, let's see if I can do. What about this behaviour? That's stepping. What's going on there? She was in a pretty good mood that day. She wasn't obviously distressed. But then we didn't try and stop her. We didn't try and make her walk normally. What would have happened if we had tried to? Well, I can tell you actually, she would get very angry. She has to do those steps. She has to do them at certain places. They're not in a rhythm, which would be another sort of explanation. She has to do those steps. She's got a whole series of things that she has to do. And again, to me, because she's getting quite distressed about these things, I would suggest that these are actually a form of OCD. So what are the treatments for OCD? How am I doing time-wise? I've probably run out, haven't I? No, it's okay. Sorry, because I'm trying to be in my own chair, I've given myself a difficult job. Well, there are basically two recommended types of treatment. And in the NICE guidelines, our National Institute for Clinical Excellence, it states quite clearly that for young people, that's children under 19, we should be offering cognitive behaviour therapy first. Cognitive behaviour therapy requires good communication, good partnership working between the therapist and the child. Or alternatively, we can give drugs. Not the major tranquilizers that we've heard mentioned already, but drugs like Prozac. In fact, the particular one that's supposed to be very good for OCD is one called fluvoxamine. Now, the research I've been involved with has demonstrated that CBT for children works very well indeed. It's better probably than drugs. It has much longer lasting effects. So that really is the option that we should be choosing, and that's what our National Institute for Clinical Excellence suggests. It also suggests that for adults we should be offering them cognitive behaviour therapy before we offer drugs. There is a problem with that, which is being addressed by the government, which is that we don't have many people trained to offer the therapy at a sufficiently high standard. However, we don't really know whether CBT works for people with autism spectrum disorders. Now, Ailsa Russell is the person who's really done all this work. She's just recently moved from London to Bath. And she compared a group. She was working in London at a national clinic, and the national clinic works on the basis that people get referred up for assessment, but then their local health authority has to decide whether they want to pay for treatment. And for about half the people she saw, the local health authority would decide not to pay for treatment. So she compared those with the people who were allowed to be seen for treatment or were paid for treatment. And in this case, what she found was that a cognitive behaviour therapy that was adapted a bit for people with autism spectrum disorders worked quite well. It stopped them worrying so much. It stopped them having so many worrying thoughts. Now that's quite an achievement, and I maybe have time to show you just what sort of things you have to learn to do. But her second study, which is much more interesting and much better, much closer to gold standard study, she actually compared CBT with anxiety management. So you're comparing two active treatments, and she randomized the groups. So she had money to treat everybody that came along. So half of them got anxiety management and half of them got CBT for OCD. And then everybody got better. So do we just need to tell people with ASD how to manage their anxiety? What can we do to manage anxiety? Well, there are lots of things we can do to manage anxiety. One of them is simply communicating more clearly. Not imposing unexpected changes is a help. So the treatment techniques involved in CBT are things like psychoeducation, which is just a fancy name for teaching people what happens or explaining what happens. Behavioural experiments, actually persuading people to do things that they wouldn't otherwise do. And let's take the example of spider phobia, given that that's been mentioned already today. If you're a real spider phobic, the chances are you would have looked around this room when you walked in. You won't have known you were doing it, but actually you would have looked for the places where the spiders would be. Now I can tell you, because I spend time with spider phobics, that those light fittings are absolutely fantastic for spiders. And as for that roof, well, there could be some really socking great spiders in here if they don't have really good cleaners. Oh, and look at all those vents. You know, wonderful. And we're just about the right season for spiders, aren't we, at the moment? Those of you who are frightened of spiders will know all that. So my behavioural experiment would be to ask you to walk into the room and look at the floor, not at the ceiling, not at the corners of the room. What happens? Well, you get very anxious because you think there might be a spider. And do you know what spiders do? They bite you, don't they? There are very few spiders that bite and very, very many fewer that cause any damage. So we don't actually need to worry about spiders. Okay, so that's an example of a behavioural experiment. And it would be used to try and change your pattern of thinking. And the final thing is to actually get people to face up to their fears, do things that they're frightened of. If you're frightened of flying, you're not going to get over it by staying on the ground. You've actually got to go up in an aeroplane at some stage. We'll do some work with you beforehand, and British Airways will send you a package of, or I think it's British Airways, it might be Virgin Atlantic, we'll do a package of flight phobia treatment for you at a cost, and then you get a chance to fly around London in a aeroplane, a jet. I don't know that it's very exciting flying around London. I prefer flying over the Alps because the mountains are much more impressive than the city. But anyway, that's just me. So we get you to face up to your worst fears. Okay, what's this? How many of you here, and I do want a show of hands, how many of you here had thought about llamas before I brought that slide up today? One person. Is that because you have llamas at home? Okay. Now, what I'm going to do is I'm going to take this picture away, and I'm going to not talk. I'm not going to do anything for a minute. And everybody who thinks of llamas, you're not allowed to think of llamas from now on. When I take the picture away, anybody who thinks of llamas, put their hand up. Okay? I don't know that I can bear to wait for a minute, frankly. Okay. The fact is we don't control our thoughts. It's quite a surprise to most people. But what we know as psychologists is that thoughts aren't really under control. If they were under control, we'd only have them when we wanted them. And that's clearly not the case. People are sitting here now thinking what are they going to have for lunch? Is there time for a loo break in between the two speakers? What are they going to do for supper? How are they going to get home? Have I got my ticket with me? Oh my God, I forgot to put that on the shopping list. Oh God, what's my husband doing now? You know, all of these things are probably going through your heads instead of listening to me. Am I surprised? No. I'm a psychologist. I'm used to it. People get bored with me. Well, maybe not all of you. So that's an example of a thing that we do regularly with children. I don't normally use the llama. That llama was my llama, one of my llamas. I normally talk about pink giraffes or blue zebras, depending on whether I'm on the ground floor and they can see them out of the window, or on the first floor where they can see them out of the window. You can't see a zebra so easily, but you can see a giraffe because the giraffe looks in through the window, usually eating a leaf. Now, when I talk to people about pink giraffes eating leaves, they say, oh yes, I can imagine that. And then I ask them to stop thinking about pink giraffes eating leaves. It's very difficult. You can't actually get rid of thoughts. And that's very important because people with OCD want to get rid of their thoughts. And they think that to get rid of their thoughts, they have to push them out of their heads. You just can't. If anything, it makes it worse. Okay, now the final thing is to talk about the functions of behavior. Why do people do what they do? And I think this is a very useful technique. And there are a number of ways in which you can find out why people do what they do. People do things because they get rewards for doing it. They get pleasure out of it. Punishments aren't very effective, actually. It's not really very useful in the long term to smack people or to hit people, apart from the fact that that's now forbidden by the government, of course. But taking privileges away isn't the right way to do things. The best way of doing things is to provide positive reinforcement, provide rewards for doing things, not before they do it. I mean, just think how much money did we give to Idi Amin in foreign aid, or any of these dictators in Africa? And did it make them better people? That's called a bribe. That's not a reward. The reward would be after changes occurred. And the four commonest functions of unusual behavior in people with disabilities are to get attention, because they can't communicate any other way. If I wanted to get someone's attention, I would either stand in front of them and sort of look interested, or I might come and touch them on the arm, or I might do something like that. Now, if I do that to someone with autism, they won't actually like me usually. So I would try and do it a different way. People often do things to try and escape from the demands that are placed upon them. Imagine if I made you all sit maths GCSE now. How would you feel? Some people do stuff because they get a buzz out of doing it. Sensory reinforcement is probably a bit like that. So the bouncing on the trampoline that Ros has mentioned, the skating, swimming. Swimming is quite different in sensation from walking. Walking itself is different. And people with autism often try and do stuff to get away from other people. And there are lots of ways we can find out which of these functions behavior fulfills. Most of these are pretty obvious. You can observe, you can interview care staff, And probably the most powerful method is actually to do an experimental assessment. And I just want to show you this one last slide, which is about repetitive behaviour in undergraduates. Undergraduate psychologists are a fertile source for experimental populations. And the reason for that is that we bribe them with credits towards their courses. No, of course we don't. No, they just get these credits automatically and then they're allowed to do experiments on each other. That's the way it works. It's a closed economic system. It's perfectly safe and ethical. So what we did here was we gave people who admitted that they bit their nails, we put them in various situations. And I mentioned doing maths GCSE. We call that frustration, because psychology undergraduates are all supposed to have fairly good maths, but giving them maths GCSE papers to do does not fill them with a lot of happiness. So we call it frustration. Or we gave them nothing to do at all. We made them sit in a room for 10 minutes. Or we talked to them. We chatted with them for 10 minutes about all sorts of stuff. Or we gave them something to do, like watch a film, and told them off every time they bit their nails. But the thing that made them bite their nails most, this is a repetitive behaviour, is boredom. Followed by frustration. Well, that's interesting. First time anybody's given such a clear description over a number of subjects. I think there were 40 people took part in this study. So actually, you can get people to bite their nails by making them bored. And you can get them to stop biting their nails if you put someone in the room with them, which isn't on this slide, which is quite interesting. Why would that be? It's some sort of social pressure. But what that is, we don't yet know, and we need to find out, and that would need further experiments. There are people with autism spectrum disorders who bite their nails. I'd love to know why they do it, but there aren't very many. I think there are probably fewer people with autism spectrum disorders who bite their nails than there are typically developing people who bite their nails. So that's an experimental way of finding out what the function of the behaviour is. It's relieving boredom in some way. It's actually giving somebody something to do. And at that point, I've got 2 minutes left. I shall stop there, which allows people to ask one, possibly 2 questions if they're quick, and then I'll hand over to Kathy Tissot. Silence. Oh, that's good. Sorry, one over there. Do you want... Oh, and one over there, okay.
The young man that was having difficulty crossing that threshold,
Yeah.
was it actually an obsession or was it his difficulty with sensory integration?
How would you define the difference?
The difference, I suppose, would be sensory integration having difficulty in processing, moving from one environment, one room into another, and the fears that are associated with the mismatch that he gets through all his senses and creates that. And I suppose on the other side, the obsession with the lines factor that you were talking about, crossing over that line. So how would you go about finding out which of those it would be?
I think the practical answer is that I'm not sure I need to know the difference. What I need to know is that he's motivated by fear or discomfort. Right. So I would want to find a way of making it less discomforting for him. So what I might do in the case of a threshold, and he doesn't only stop on thresholds, it just so happens that was a threshold, is I could put bright sticky tape across the threshold at right angles to the actual threshold itself. So if it's a door frame, if you can imagine putting sticky tape this way or at angles rather than in line with the door frame, that's likely to break up the door frame and would enable me to get through. Now, this is something we've also found in Parkinson's disease. In Parkinson's disease, there's a similar phenomenon where you can, I have to get this right, you can step if you're going across a zebra crossing, but if you're going along a featureless floor, you can't. I think it's that way round. And so there's some sort of visual sensory phenomenon there. But there are other disorders where this problem of the threshold occurs. And it may well be sensory. I don't know. I was putting those people up because I think that they are distressed by what they're doing and what's happening. And on that basis, it meets the definition of obsessive-compulsive disorder.
Thank you.
And one more question over here. Yes?
Could you say something about the girl we had here who had the dog phobia? Did that teach you anything about OCD already?
No, nothing to do with OCD, sorry. I can talk about dog phobia, but that's a different talk. Sorry, there was a lady there. Yes?
If you have very severe autism and challenging behaviour, that also looks like there are features of OCD in there. How, as a practitioner, is it ever possible to really sort that out?
Is it ever? Well, I'm an optimist, you see. Otherwise, I don't think I'd work with this population. Well, I don't know. I'm an optimist anyway. My wife would disagree. She says I'm a pessimist, but I'm an optimist, I say. And I would say, yes, it is possible, but it might take quite a while. And it will require, first of all, careful observation, discussion with people who know that person better than I ever will. I'm always ever the consultant type person. I'm never actually the carer. So the carer is going to tell me most. But my observations might tell me quite a lot. And then finally, I would do something like that experiment. I would actually try and get people to do things with that young man or young woman and see whether I could make it easier for them in some way, and then use that time.
And can you just say a bit more about what you said at the beginning about the age at which OCD becomes apparent?
Which what, sorry? The
OCD becomes apparent. I think you
OCD
said when
is
it's
most
during their
commonly,
teens.
the most common age of onset of OCD is during the teenage years. And the reason that I'm not 100% sure about that is because I see mostly teenagers with OCD, and most of them have had OCD for many years by the time they come to me.